So I have the dubious distinction to follow two excellent speakers and be the only thing between you and lunch. So I do go by Trip. Chester's a cruel historic family joke that's been played on 3 generations of the males in my family. And I'm what's called a painiac, if you deal with pain. Pain's sort of an orphan disease. Nobody likes pain. Nobody likes to treat pain. $900 million investment by the DoD in TBI and post-traumatic stress, which is excellent. Same time frame, about $47 million invested in pain. And yet, the number one reason why a veteran is going to show up at a veterans hospital today is pain. So I do think in the research community we have a disconnect, and I'm pleased to see that's changing. I want to talk to you today about some of the things that we're trying to do in the DoD. We have in the audience Lieutenant General, retired, like me, but he's employed. I'm not currently. General Shoemaker, who actually, right at the height of the war, was involved in really bringing the DoD into the 21st century as far as pain management was concerned. When I first got out there, the answer for pain on the battlefield was morphine. And if you had more pain, you got morphine. Morphine, morphine, morphine. It's been a monotherapy, opioid-based treatment paradigm that we came into these conflicts. I'm very pleased to say that that's changed, but we still have difficulties, like understanding who's in pain. You don't come with a measurement bar on your forehead. There's not a blood test that I can go get to determine pain. I'll tell you an interesting story about my experience while I was out there with the British. The US Air Force got frustrated because I was complaining that the soldiers were getting on the aircraft still in a lot of pain because we didn't have the mechanisms that we needed to do a better job. So they made an edict, and they said nobody will get on the plane if their pain's greater than a 4 on a verbal analog scale. Guess what happened within 24 hours? There was not a soldier in that facility that had a pain greater than 4. So those are some of the challenges we have, not to mention a military that still embodies this attitude. These are the people that we actually want to be thinking this way because of the work that they do. But we have to figure out ways that we can better understand, after they've given this service, what they're going through and how to understand their pain so we can better treat it. I don't have any of these. I'm not smart enough. I've been retired, so I have been doing a little consulting work so I can eat, but nothing with these companies has to do with anything I'm going to discuss today, and nothing that I'm expressing anybody's going to take responsibility for, including the Department of Defense, the Uniformed Services University, or the U.S. government. Let's see if I'm able to get this to work.
Hey, check this chart out. This guy says he's been in pain for like 3 months.
For doctors, pain is complicated. Every patient handles it differently depending on their race.
Does what,
Gender.
Ow, I just bit the inside of my lip. Ah, nothing has ever hurt so bad.
Or even their sex life.
Oh, yeah.
And since there's no way to truly gauge how much pain someone's in, we have to rely on an archaic chart.
Mr. Peel, you're about a 7 on the pain chart. Yep, you're 7.
What's a 10?
So I had to cut the clip there because what they described as a 10 was not really appropriate for this audience. But it does illustrate a point, because your 10 is going to be very different from mine. Sometimes in these lectures, and I'm not going to because of the time constraints, I'd ask the audience, well, what's your 10? And I'll get answers like, well, being burned alive, nailed to a stake, dragged behind an aircraft. I got an answer one time. Giving birth to a baby. None of those things have ever happened to me. So I don't know what to do with that as a clinician, and as a researcher, I really don't know what to do with that. But that's what we've been using. What's your pain? Well, if you want to get your steak for Percocet poker in the barracks that evening, you're told by another soldier, tell the doc your pain's 10 out of 10. My pain's 10 out of 10. And that's essentially where we've stopped in the DoD understanding this issue. We finally actually started asking the question. We asked the question dutifully, just like everybody else, because it's a Joint Commission mandated statistic, right? You have to ask about pain. And we ask, and we check that box. Just like we were doing out in Afghanistan. What's your pain? Can I get on the flight if it's a 6? No, then it's a 4. And off we went. We're doing the same thing in our military hospitals. We're actually even advancing and asking in the Joint Theater Trauma Registry, a very important registry that's going to essentially drive combat casualty care for the next couple of decades. We're asking that pain question. But we never ask it the same way twice. We never ask it the same period when they're coming through the system. And we never have any standard by which that information is recorded from a time course as far as the therapy. For all the researchers in the audience, what are you going to do with that data? Same thing I'm going to do. Absolutely nothing. But we're recording it. We are asking that question. So there's lots of pain scales out there. I'm going to go through this very fast. And there's tons of literature. Far more literature than I have in the time that I have right now to go through, and that's not my goal. I cherry-picked some information just to make a point. There's some good scales out there that you can go ahead and look at. And you can find studies that will support using those scales in a variety of different populations. In this particular population, which was elderly, they found that the VDS, Visual Descriptive Scale, was the most sensitive and reliable. But if you go to African American community or Hispanics or impaired, they would rather look at faces. So it's difficult to really understand. Again, you have to be asking the right questions in your research if your data is going to have any meaning for the population that you're trying to look at. And then as part of the pain task force that General Schoonmaker was leading, we were tasked, we were given a mission. In the military, we're very simple. We're all about mission orientation. Go out and find out from our hospitals and clinicians, how are we doing with pain? And the good news is we were meeting a standard that you would recognize in any civilian hospital. We were dutifully checking the box, asking patients about their pain using that scale. And when we asked the next question, what are you doing with that information? They were giving us the same answer that I just gave you. We're not doing anything with that information. It's not really clinically relevant. It's inconsistently administered. It has no functional anchors, and it's considered to have little value by clinicians at all levels. Now, right now, there's researchers in the audience saying, damn you, Buckenmaier, I use that scale in my research, and I do good research. I am not criticizing your research. That numeric rating scale is just fine in a controlled research situation where you're controlling all the parameters. But how often are you doing that clinically? The answer is you're not. And what does that data really give you as far as valuable information in managing the pain? Particularly if the soldier just wants something from you. What's your pain? It's a 10. It was a 10 last week, doc. It's a 10 now. It's going to be a 10 next time. So how are we supposed to gauge, with all the tools we have in our toolbox right now, including opioids, to manage that pain with that information? Because if the goal is to get their pain to 0, right? That's the goal. Because I'd suggest to you that that's the wrong goal. Because I'm an anesthesiologist. There's nobody in this audience that I can't get your pain to 0. I guarantee it. Every single time. But the situation we were creating with our wounded was mom or dad or the spouse would be on the couch with a pain of 0 because we've been treating them, watching I Love Lucy, and the kids would go off to school. And when the kids got back from school, that spouse or son or daughter still on the couch watching I Love Lucy, their pain's still 0. Is that success in managing pain? And we haven't even, as the slide will show later, even talked about, well, what if they have other morbidities such as PTSD or TBI? How is that pain contributing to those issues? So we've really had to think about redefining what success meant. And if you haven't ever seen this document, it's on our website. It's available from the Army website. It's a very interesting read and a quick read. So we were told we want you to be able to measure pain intensity, mood, stress, and the psychosocial impact of pain. And we want to have a standardized tool at all levels, and we wanted it to be practical and applicable to any clinical setting. Easy, right? We'll get right on that. This is actually what we came up with. It's called the Defense and Veterans Pain Rating Scale, and I'm introducing this first because this is the pathway by which we learned about Richard and Northwestern and the whole PROMIS issue. I'll tell you an interesting thing with the next slide about these faces. First of all, I want to say that this was designed to be used in a variety of different clinical situations. Clinical situations where people don't speak our language, they don't necessarily share our culture, but we needed to be able to understand in a quick interaction where their pain was with some sort of scale. And that's why it has these elements. But the insane thing that some people think we did is we decided to give a pain of 7 a definition. Focus of attention prevents doing daily activities. We defined each one of those numbers so that when we ask this question, at least in the DoD, it's not whatever the patient feels their pain is. And I know that's warm and fluffy and that gives us a good feeling. Pain is whatever the patient says it is. But when you're using that sort of standard, you can't really create standards on how you're going to manage it. So we decided to provide these definitions to our soldiers to give them some sort of grounding. This is just a start, though. It's still not enough information. The IASP, because the faces that the IASP owns are actually excellent faces that we originally used in this tool. We were talking about whether or not a tool is free or not. This is absolutely free. You can use it tomorrow. Yes, you can use it in your research. If you modify it, you just can't call it the DVPRS. Otherwise, you can do whatever you want with it. You've already paid for it as an American taxpayer. But they wouldn't let us use the IASP faces. We had to develop our own DoD faces, so you also own these faces. I asked my crack team at the Defense and Veterans Center for Integrative Pain Management, the organization I used to direct, to come up with faces. This was their first stab at it. So my crack team at the DVCIPM and I had a little discussion. But we also, if we flip over the card, one of the things that we're very interested in is there's more to pain than just that number. How is that pain interfering with your activity, your sleep, your mood, your stress? These are things as a pain physician I deal with all the time. I intuitively know that these are issues. But honestly, how often was I asking these questions on my clinical rounds? And the answer was I really wasn't, because I hadn't really determined that to be a standard. So we've gone ahead and looked at this. This is the first validation study. There's a number of studies out there that are ongoing. I can say to you with confidence, it is at least as valid as any of the other previous scales that I just showed you. This is looking at, because what we're very interested in is this functional language. As you can imagine, in the mid portion of the scale, when people had errors in matching up the language with the actual number, this is where they would have the error. But you'll notice that that error is very small. The red bar here says that they were only off by 1, and that those people that were off by more than that were a relatively small percentage of the patients that we looked at. And of course, this research is available on our website. So what can you do with this information? This is an actual clinical record. Of course, it's de-identified from Walter Reed right across the street. Overnight, we were able to see that a lot of our patients were having difficulty with sleep. And this is also an interesting story. We knew this was going on because our soldiers were complaining about it to us all the time, but we really didn't have a measure. We instituted this DVPRS, and I had a number, at least half, and most of the time, 75% of the patients at any given time were a 7 or greater on this simple scale for problems with sleep. Why was that? Well, we asked a simple question of the nurses, and we found that what does a nurse dutifully do at 2 or 3 o'clock in the morning to check a box? Take vital signs. And so we instituted a policy that was very simple of sleep hygiene, where we could actually, with a doctor's order, prevent that one activity from happening and improve sleep. It seems silly, but these things are all very related. I don't have to tell this audience how important sleep is to rehabilitation and recovery. And with a simple tool like this, we're able to determine. That's obviously just one example. You can see all sorts of trends with this data. This is actually another patient that we actually trended the graph. What happened on day 4? They went back to the OR. What happened here on day 9 and 10? They're getting ready to leave. And they actually are able to leave. And I'm not having to say to them, well, if you tell us that your pain's less than a 4, you get to leave. This is a very powerful tool, and it has potential using some of the things we heard this morning about leveraging modern cell phone technology, modern telecommunications. Wouldn't it be a wonderful thing to ask these simple questions using that tool on the patient's cell phone, something that these young people are very used to using? I can't get my kids to talk on the phone, but they'll spend an hour texting each other just to go set up a movie. Ask them this question about their pain prior to us going up to visit them clinically. So instead of wasting time collecting this data, I could have the data and then go act on it by talking with the patient. And these are some of the things that we're working on right now. So why is this important? Well, we have an issue going on right now. Just 2% of the active duty population in 2002 described misusing prescription drugs. Now remember, this is a population that's not used to describing about their supposed misuse of medications. So I would imagine that 2% is pretty low. But look what happened in 2008. 2009 was probably the height of the most recent conflicts. It went up to 11%. So we have an issue, particularly with the monotherapy that we've traditionally used in not just the military, but in this country to manage pain, which is opioids. Pain equals opioids. And I'll let you go ahead and read this for yourself, but this is a real issue for many of our soldiers. We've gotten very good at taking care of the red badges of courage, right? We can mend the bone, we can stop the bleeding, we can sew up the wound. We are fantastic at that. The #1 trauma center on the planet right now isn't anywhere in the United States, it's in Afghanistan. I truly believe that. Best place to be shot or hit by a bus is in Afghanistan right now with the military system that we've established. But what about these issues of pain? Once they've recovered from these other conditions, have they truly recovered? As I refer back to that analogy of the patient on the couch, if they're still dealing with issues of chronic pain. And then there's the relationship between chronic pain, PTSD, and TBI. You can't really diagnose those other conditions if you don't have a handle on the pain. You know, I was fascinated by the earlier lecture concerning these auditory signatures. Wouldn't it be wonderful to understand if there's an auditory signature for pain? What an interesting area of study. I'll quickly go through this because you can find all this information for yourself on any CDC website, and it makes sense. As the sales for narcotics have gone up, because our treatment of pain has actually gone up, the deaths have gone up. And interestingly enough, if you have 100 milliequivalents or 100 milligram equivalents of morphine from an opioid load on your system, you're at a significant 9-fold increased risk of death. Wow, for a polytrauma patient, that ain't nothing. That's a whiff of narcotic. And this really struck me. I use this slide quite often. For every death that we hear about, for every tragedy, for every one of those patients that's gone on the bridge and jumped, and we're, as a DOD, left there looking at the splash and wondering, why did that happen? And could we have done something to intervene? And we pour into the charts to say, was there a signal that we could have looked at that could have prevented that death? But then look at all the morbidity that's associated with that one death in other patients. This is a huge issue that's going on, not just for the DOD. The DOD is a reflection of you, civilian medicine. This is a national problem. We just happen to be focused a little bit more because war tends to focus things. It tends to be a catalyst, as Major General Thomas likes to say, of positive medical change. Alex Kahana, who's been a partner through a lot of this stuff, particularly in seeking evidence-based medicine, as we learned with PROMIS, if you want to ask these questions, you got to make it easy. You need to create the evidence to make good decisions. And I love this statement because I'm neither for or against opioids either. But by the way, I'm neither for or against acupuncture. I'm neither for or against massage. I'm for whatever's going to work for the individual that's in front of me at that moment. And I'm against anything that's just a cookbook, knee-jerk, or financially driven reason to do something, which unfortunately drives a lot of the care that we do today. My problem is, as a Painiac, I don't know which to choose. I don't know which one is the best because hopefully I've just described to you, we don't have the data. The salient failure of my 26-year Army career is we know no more about pain now, after 13 years of conflict in our soldiers, than we did when we got started. I have some miserable papers that are out there where I tried to get that answer, but they're miserable papers. We didn't have the instruments to actually ask this question. So the Pain Management Task Force, again, told us, do this. Go out and make us a system that will collect the data that we need to get this information. This was a problem statement. Pain is the #1 reason veterans seek care. That's enough of a reason to be interested in this issue. So I did a little mental masturbation, if you will. I went to the Oracle, Google, went on Google Scholar, because I just wanted to say, you know, back pain, because this is a barroom discussion. I'm not standing behind any of this data. But I said, could I go out and find Archives of Internal Medicine, a paper on chronic back pain that would say that acupuncture worked. 17,000 patients at a cost of about $100 a visit. Again, these are barroom statistics. Let's say 10 visits. I do medical acupuncture. That's reasonable for back pain. $1,000 cost. And it works. This article says so. It's a meta-analysis, right? So it's got to be true. Well, I can go to spinal cord stimulation for patients. I can find the same supportive evidence that it does get better. Now, this one has the downside that when you stick a device in somebody, the adverse events go up 34%, but let's set that aside for the second. Look at the cost. But again, I'm neither for or against acupuncture or spinal cord stimulators. In my experience, spinal cord stimulators have been life-saving for a number of patients. Again, how do you choose? Everything I've been discussing, hopefully, this audience recognizes is right out of the IOM report on pain. Just some quick definitions, what PASTOR and PROMIS. PASTOR, and I didn't come up with the acronym, it was just a holding title for something that we wanted to do in the DoD through the Pain Task Force, Pain Assessment Screening Tool and Outcomes Registry. That's what we wanted. In our search for how to do it, we stumbled across the very important NIH project of PROMIS, a $100 million effort to tell us how we should be asking these questions. In our research organization right now, if there's a PROMIS tool that we can use, we ignore all the legacy tools and we use the PROMIS tools so that our research will make sense with other people who are using those same tools. Lots of people are behind this idea. And that's what it makes me feel good. Makes General Schoonmaker feel good because he doesn't think I'm all that smart, but when all these people say that this is a good idea, then my advice is probably decent. This is what we wanted it to do. We wanted a clinical assessment. It had to be a clinically valuable tool that would help manage the individual patient, provide a way to make better decisions, but we also wanted an ability to create a registry so we could start asking questions. What are the right patients for spinal cord stimulation? What are the right patients for acupuncture? Or a combination of the two. This is what the report looks like. This is the culmination of many, many years, about 5 years at this point of effort. Richard's been very much involved in this. Karen Cook has been a very close partner of mine, also working for Northwestern. It provides a pain map. We track the opioids because that's such an important statistic. This is the DVPRS, but importantly, it's the DVPRS that's tracked out over multiple visits. So that information begins to have some meaning. This is a very important portion of it. Wouldn't it be nice, instead of staring at the splash, to ask these questions in a routine appointment and give the patient an opportunity to throw out a foul card or throw out a warning sign and say, I'm having issues. So we have screeners in there for suicidal ideation, PTSD, alcohol abuse, depression, anxiety, things that clinicians should probably deal with that day. And again, of course, we're collecting all these statistics. The meat of it, though, are the PROMIS measures. We can get all this information in under 20 minutes. Our goal is to get under 15 minutes. The only way that we could ask things about depression and anxiety and anger, if we were using standard non-PROMIS instruments, the patient would be in there for hours. Do any of you know any soldiers that are willing to do that? I haven't met one yet. I'm not willing to do it. When they gave me that question battery at the end when I got back, you know, the post-deployment, and there's people in the audience that are going to hate me for this, but I know how to answer that bad boy, and I whip right through it in 15 minutes, even though it should have taken me hours. We have to find ways of asking these questions in a non-threatening and a non-burdensome way, and I think PROMIS does a very good job. The beauty of this is the clinician, we make it agonizingly simple. Again, I'm in the Army, it's got to be simple. These arrows go to better health, and I can follow these trends to these parameters. So it's okay that Private Snuffy's pain is still an 8 out of 10. And it was an 8 out of 10 last week, and an 8 out of 10 next week. If I'm able to look at these parameters and say, well, Snuffy, look at all these other areas that you've improved in, maybe this therapeutic plan that doesn't involve that many opioids, maybe it involves massage and acupuncture and biofeedback and musical therapy, it seems to be working for you. That's what this is all about. But for it to have meaning, it has to be used ubiquitously. It has to be used by the entire system. That's the challenge that we're having right now. We're still in a pilot stage with this at the moment. It's about achieving this big fish. I can't answer this subtle question from the data that I just showed you. I can show you the meta-analysis about spinal cord stimulators and acupuncture, but I can't tell you which one is going to be best for the patient that's in front of me. It's still, pain medicine is still done like this. You look like an 8 to me. That's what we do. We base it on our experience because we don't have the data that we need to make better decisions. That's what all this is about. Gotta love an Army that would put up a billboard like this. If you, you know, people have been asking me, how do I like retirement? I loathe it. I hate it. I absolutely hate it because none of my colleagues have accepted that I've retired, and I really miss working with this population. This has been my life, and people told me I would miss it. I thought it would take at least a few months for me to miss it. It took a few hours. This is our website, and if you want to look about our, follow us with our work on the, it's a rather long website tool there, but Pain Assessment Screening Tool and Outcomes Registry are passed through. Thank you very much for your attention.
We do have time for a couple of questions. Thank you, Colonel Buckenmaier. You are always an entertaining and compelling speaker.
Hi, thanks for a wonderful presentation, entertaining.
You know, my wife never says that. I'm sorry.
There are brain areas that correlate with pain, and they focus in the somatosensory one and secondary areas in the anterior cingulate cortex and the insular and prefrontal areas as well. So those are kind of measurable. It doesn't guarantee that the patient's feeling what the brain says it is. But combining that with morphine pain medications that can create addictions, and that creates problems for therapists and clinicians to move in with ARTS programming. There's a considerable literature that it's hard to penetrate through addiction. So I guess what I want to ask you is just the power of addiction over these sensory pathways, if you're aware of that literature, and integrating the modalities to move into to recruit and retrain and rescue these pain pathways.
It's a difficult question, but an excellent question. After 200 years of benign neglect in this country for pain, we stumbled on morphine in 1803, and it works. It works every single time. Like I said, I'm an anesthesiologist. I can make your pain zero every single time. We thought that was the goal, but now we're figuring out it's a far more complex problem, as you just outlined. Wouldn't it be wonderful if we actually asked better questions like we're asking with this PASTOR tool based on the engine of PROMIS, and then combine that with all of these things that we've been talking about today, such as the auditory brain signatures. It's TBI and PTSD and its influence on that, that's great. But what about pain? What about chronic pain patients? But you take that question and you add a standardized battery of questions where you're asking everybody in the DoD the same sorts of things, but using computer adaptive testing so it's far more difficult to gain. We're embarking, despite the fact that we don't have the evidence right now in the DoD, on embracing integrative medicine. But the frustration we have all the time is the data just isn't there when our bosses say, okay, I'm going to make an investment in this. Where are you going to show me that if I make this investment, X number of soldiers are going to get better? Mm-hmm. And that's the promise of this information. I believe if we're able to get it out like we're trying to right now and used routinely within our system, from a research standpoint, it'll be huge. It'll be massive. But just from the standpoint of being able to get functional data on which soldiers, which sorts of conditions can I send a soldier for $1,000 worth of acupuncture as opposed to a spinal cord stimulator. And the reality today is that TRICARE covers the spinal cord stimulator. It does not cover the $1,000 of acupuncture. We still do it, but it's not covered. I don't know if that answered your question. Your question's essentially at the heart of the complexity of what we're trying to accomplish.
Right, and it's my agenda too to move in with the arts and to help rescue these situations too. I guess my question was about more, and I'm not an expert on addiction, but I know that addiction and pain medications quickly become the new normal. So the physiology becomes adapted to the pain medication. You take it to feel normal. So our job is to move in and work from the normal while the medicine is being titrated to lower dosages and to strategize to get in there and to recruit the physiology, the motor movements and brain mechanisms networks that come with that, monitor those networks. It's just a strategy that needs to be developed with an addiction. Addiction's a special case. It's hard to break through it with music, I know.
But we have lots of soldiers out there that are dependent, which are a special case also.
That's what I'm asking.
But the issue here for you is I can't tell you what normal is with an NRS number. Like the pain is an 8 and we're done.
Right.
What this is going to do is give you far more information about what normal looks like and what abnormal looks like in a patient. They may be functional on their opioids, but when we get all this other biopsychosocial information about function in their daily lives, we'll be able to because we can show our patients these graphs and say, yes, you're demanding this opioid, which is a problem right now because it makes you feel normal. But look how abnormal you actually are. Right. And if we tried some of these other things that would allow you better function in these other areas, maybe that's the normalcy that you're really wanting. That's a conversation that's exquisitely difficult for me to have with a soldier right now who's in agony. Just give me the drug that makes the agony go away. But we have to build the evidence as a community to make that argument to our patients. I'm not comfortable really making that argument today because it's still, most of what I'm saying right now is still opinion.
I think music can escort those desired outcomes, and that's why we're here. Thank you.
And this could be something that you could use to study that.
Thank you.
Absolutely.